Anupam Sibal. I'm the Group Medical Director of the Apollo Hospitals Group and a Senior Pediatric Gastroenterologist and Hepatologist at Apollo Hospital, Delhi.
Hi, I'm Anil Dhawan. I'm a Professor of Pediatric Liver Disease at King's College Hospital. I'm also the Corporate Medical Director for Variety Children's Hospital at the King's College Hospital.
So Anil, great having this conversation with you. Wanted to ask you what's new in the world of neonatal cholestasis. It's such a common problem for us everywhere in the world.
Yeah, so if you generally look at in terms of incidence, so when we define neonatal cholestasis by baby being yellow with pale or with or without pale stools, is increasing. I think partly because of the prematurity, the babies that are getting parenteral nutrition, sepsis, all those, they're living longer. So generally, if you look at the number is increasing. But what is decreasing is, if you remember 20 years, 10 years back, we used to call it so-called idiopathic neonatal hepatitis or giant cell hepatitis. I think that particular part is shrinking now because with the molecular diagnostics and genomics, I think we are identifying those conditions. They were there, but we didn't quite know what to call them. So we will put them into a basket-based paper basket diagnosis of giant cell hepatitis. So that group, every few years you see one new gene described. So late acid gene, TJP2 or DCD, ciliopathies, etc. Another group that has emerging now is RNA translation defects. So at the level when the RNA is translated, when it makes the protein at that level. So the recurrent acute liver failure syndromes are coming out of that. Then mitochondrial disease we knew for a long time, but I think increasingly we are better at recognizing. But what is not really has got better, the speed it should have is the early diagnosis of biliary atresia. I think that still is a challenge. Every single country, the whole sector has tried to address it, but the age at Kasai is very difficult to shift. It does shift by a few days, but it doesn't come down to 3 weeks or 4 weeks. So I think there is the work to be done on that particular one. That is the most common cause for a tertiary center, biliary atresia. In our setup, 20% of our neonatal cholestasis children are biliary atresia. 10% are alpha-1, 5% are PFIC, and other genetic rare disorders, another 5%. And then still the bulk stays, about 40% is so-called idiopathic one. And that is a one which needs teased out further.
When we look at the scenario in India, neonatal cholestasis still is a very common problem, and like you're seeing in the West, we see more and more babies and infants with cholestasis. About a quarter of the referral work to a hepatology center would be neonatal cholestasis, and when we look at the data that's been published, about a third of all neonatal cholestasis will be obstructive. Now with the Yellow Alert campaign that started off in certain parts of North India, we've seen some traction, and Professor Yacha's group reported that from about 132 days at presentation to their center in Lucknow, in about 5 years they saw a reduction, and the babies presented at 97. But again, 97 is very late. So that is something like has shown progress, but clearly there's an opportunity there to see greater awareness, greater traction, the families recognizing it, going to a pediatrician, and the pediatrician then making a decision about referring to a center where a biopsy can be done quickly and not waste weeks and weeks. The reliance of HIDA on HIDA getting priming done with phenobarbital, wasting 5 days going from one city to another. So all that, while there has been some progress, clearly there's an opportunity for greater progress to be made there. What we're also seeing is that the number of babies with the idiopathic has come down, because what we used to have was a large number of metabolic in that idiopathic bracket. But now with the availability of better testing, greater understanding on the pathophysiology and the ability to recognize in the referral centers, the idiopathic group is shrinking, but it's pretty substantive still. Another area for improvement really is about better nutrition for these babies. Well, clearly, I think the jaundice kind of takes all the attention, and quite often the attention that needs to be given to nutrition is missed, and which, as we know, creates problems. So overall, I would say that there's significant progress. Clearly a lot needs to be done, and we wait for the day where babies with biliary atresia would say get picked up at 30 days or 40 days, and so we can offer better therapy. When we look at outcomes, some papers published early 2000 showed that the outcomes were really dismal because these babies were coming in very late. We've seen in a couple of recent publications that the survival figures with the native liver have improved, and again related to two factors: early age, relatively early age, and of course the skill of the operating team, and that has been shown very well by the work that's been done in England. But what is very gratifying is that a baby born in the mid-90s in India with neonatal cholestasis had just about a 20% chance of survival with a native liver because there was no transplantation, and now a baby born in 2019 has a 90% chance of living with a combination of either a Kasai followed by a liver transplant, or in some cases a primary liver transplant.
So I think you raised two important issues when you were describing the development and progress that has been made. You alluded to the metabolic diagnosis. So obviously things have gone faster. Where do you think the Indian model is? Obviously India is such a big country, and the patients, not every city can afford a metabolic lab. So is there a push towards centralization of
So a couple of things have happened. One is a lot of screening is now happening.
But this federal funded, or it's
no, it's individual funded.
So personal
so
choice.
A lot of families are opting in, and so you will pick up G6PD.
So there are some common conditions.
So there are about 11, and then there's another one with about 30.
So it's a Guthrie card-like thing?
Exactly. So that's happening. But what is now very positive is that the awareness about metabolic diseases has improved, and while we were in a position really to do some of the analysis, whether it was genetics or enzyme assays, but now with the wider availability of genetic testing, so at about 30,000 rupees you can get an answer in about 3 weeks
and
of all the common mutations,
local?
And that's pretty.
That's done in India.
Well, they are collaboration, so they have collection centers. So you send the lab, we get a report in about 3 weeks.
3 weeks.
Yes. So
that's
which
fantastic.
and at 30,000, so you're able to pick up PFIC. You're able to say, well, this is PFIC3 or not. You don't have to worry about the stains with the biopsy and all. So that has definitely improved. We are picking up our understanding of Wilson's, which is the commonest metabolic condition that we see. Looking at the mutations there, if we look at GSD, that is an entity that is being recognized more and more. We're also picking up organic acidemias, with the metabolic screening that's now readily available. So significant progress, and the availability of formula now, which I think
this was the next thing I was going to go to, because I remember the old days that getting a medium chain triglyceride-rich formula was a nightmare, or a galactose-free diet, or a tyrosinemia amino acid.
Yes.
So that availability.
Yeah, that is all available from MSUD to all the
formulas.
formulas.
A big achievement,
And I think one of the greatest satisfaction for us in this field is liver transplantation and the success. So the first child to be transplanted in India was Sanjay at Apollo Delhi, and this was on 15 November 98 when he was about 20 months old. Biliary atresia, failed Kasai. Sanjay is now finally a medical student and will become a doctor in April. So 21 years down the road, we have really the first child to have been transplanted, becoming an ambassador of leading a normal life. I think close to 2,000 pediatric liver transplants have now been performed in India. Every year about 18 to 1900 transplants are performed, and 10% are pediatric, so a variety of indications. And I think liver transplantation has got established. But I want to ask you, about the work that you've been doing with hepatocytes. So where do you see that happening?
I'm a integral part of liver transplantation. I've seen it developing from 90s to current maturity state. Now it's become a run-of-the-mill stuff, so nobody will kind of raise an eyebrow if you say liver transplantation. I have a slightly different take on it. Having seen thousands of children after liver transplantation, I think it's still a disease. And the onus is on us, people like yourself and our esteemed surgical colleague, to come up with ideas to avoid transplantation. I'm not saying transplantation is a bad thing, but if we can minimize it, avoid it, having the same quality of life, same longevity, it will be fantastic, because there's so many complications that we see are mainly immunosuppression related. If you can take that part out of it, hence the innovation has to play a big role. And liver, as you know, it's the only organ in the human body that regenerates. Okay, solid organ, other than bone marrow. So that potential has to be harnessed, and that's where the role of regenerative medicine comes in. So, role of regenerative therapies in liver disease is 2 or 3-fold. One is the inherited metabolic disorders that are liver based. They could either be treated with a autologous cell therapy after gene manipulation, gene therapies, or just an ex vivo gene therapy. That will take out around 15 to 20% of the pediatric workload in terms of transplantation. The second category, which is again about 20%, is acute liver failure, where you can use cell therapy. So either cells into the liver or the technique that you were alluding to. We have devised a first in man. The paper is coming out in Journal of Hepatology this month about using cells embedded in alginate, which is an inert algae, and that protects the cells from the immune system, but it acts like a semi-permeable membrane, so it lets the urea come out, ammonia go in, proteins come out, and it does provide growth factors to the liver and those things that are going to regenerate the liver. So that is one part of the therapy where we think that 50% of the liver transplant could be avoided, maybe more in the prospective trials or if we start early. And the third thing would be that whether we can use the cirrhotic liver as a scaffold later on. So once you are a scar, unless we get therapies that are going to dissolve the scars, so TGF beta downregulation, etc., that looks a bit of far-fetched. But if the scaffold of the liver could be used for repopulating the liver, because there are technologies now where you can remove the cellular structures and you can keep the scaffold. So I have a feeling, I strong believe in it, that not in my lifetime, maybe next generation will see liver transplantation will be a rarity, while cellular and regenerative therapies will be the mainstay of the treatment.
Lovely having this conversation with you, Anil. So for all those who look after children with liver disease, the future is promising. Thank you.
Thank you, Anupam, as always. You have been a kind of a trailblazer for, and I would say a fighter for children with liver disease in India. And the kind of work you have done is, I don't know how many people know, but I know it from outside that it's difficult when you started and you persevered. Many people would have left in the middle, but you persevered and you took liver transplantation to a kind of a mainstream operation these days. So all credit to you, my friend.
Thank you.
Keep it up.